Hi everyone. Today I'm going to discuss about optimizing the outcomes of intrauterine insemination. My name is Dr. Mintesnot I am subspecialist in reproductive endocrinology and infertility, currently working at New Leaf Fertility Center. As you all know, intrauterine insemination is one of the common procedures done for infertile couples worldwide, especially in developing countries. It is because it is simple procedure and less expensive compared to in vitro fertilization. It is more effective compared to ovulation induction and timed intercourse. Unfortunately, it is not well practiced in Ethiopia. I don't know the exact reason. It could be due to lack of awareness, knowledge, or skill. So the main purpose of today's presentation is to stimulate, inspire every gynecologist to practice this important intervention at their respective place by mobilizing nurses, lab technicians, and other responsible body. This presentation is not all about intrauterine insemination procedure. It is the whole intrauterine cycle and how to improve the outcome of intrauterine insemination at each level of intrauterine insemination cycle. The objectives of today's presentation is to give overview about intrauterine insemination, how the initial complete workup is done, how we select a good candidate for intrauterine insemination. I will also explain the whole process of intrauterine cycle, starting from ovulation induction, cycle monitoring, giving triggering drug, when to give this trigger drug, and we'll also see the general IUI procedure to optimize the outcome of IUI. And at the end of the presentation also, we'll see what are the factors affecting the success rate of intrauterine insemination. We'll see the potential complication related to intrauterine insemination, and we'll also see the alternative management option for infertile couple. These are the outlines of my presentation. In general, artificial insemination is a general term that used for sperm deposition at various parts of reproductive tract. It could be intravaginal, intracervical, intrauterine, intrafallopian, and intraperitoneal. But commonly practiced in the world is intrauterine insemination, and compared to intravaginal and intracervical insemination, intrauterine insemination is more effective compared to intrafallopian and intraperitoneal insemination. Intrauterine insemination is less invasive. So when we talk about artificial insemination, most of the time we are discussing about intrauterine insemination. So intrauterine insemination involves processing sperm inside the laboratory to concentrate the motile sperm and placing this processed sperm directly into the uterine cavity near to the fallopian tube. So when you see the history of artificial insemination, it starts with the discovery of spermatozoa by Antonio van Leeuwenhoek in 1678, and the first artificial insemination was done on animals by Lazzaro Spallanzani in 1784, resulting the birth of three puppies. The first human artificial insemination was advised by John Hunter. He advised a woman with her partner has hypospadiasis to collect his sperm in the syringe and to infuse the sperm inside her vagina by herself. Luckily, she get pregnant after this procedure, but the formal intrauterine insemination was done by John Marius Smith in 19th century. He did for 6 couples and he succeeded in one of the couple. And the first therapeutic donor insemination was done by William Pancras in 1884. The first frozen sperm was used for artificial insemination in 1953 by Sherman Jerome. And in 2017, ISHRE emphasized IUI as the most efficient treatment for unexplained infertility. Currently, IUI is one of the most widely performed procedures in reproductive endocrinology and infertility, especially in developing countries. As I have said before, it is not well practiced in Ethiopia, so the main purpose of today's presentation is to stimulate and inspire every gynecologist to practice this important procedure. So, how IUI is preferred over natural intercourse? As you all know, in natural intercourse, out of all sperm deposits in the vagina, only 0.1% of spermatozoa reach at the site of fertilization. That means if you have 14 million motile sperm, only one reach at the site of fertilization. While in intrauterine insemination, after processing all the sperms, we bypass the vagina and the cervix and we directly deposit those concentrated sperm inside the uterine cavity. That means we are ensuring millions of sperm to reach at the site of fertilization. Not only that, during the process of IUI, we also do ovulation induction that will increase the number of oocytes. So in general, we are increasing the density of gametes, both sperm and oocytes. Additionally, by doing sperm washing during the process of IUI, we are inducing acrosomal reaction, we are activating sperm. So this will ensure more healthy sperm to reach at the site of fertilization. We are also removing toxins, so we are increasing the safety of intrauterine insemination. In addition to that, we are removing some infectious diseases like HIV during the process of sperm washing. So it is not only increasing the chance of pregnancy, we are also preventing the transmission of some sexually transmitted diseases like HIV. So it is also preferred in a patient with discordant in HIV. With IUI also, we are correcting faulty coital techniques. In a patient with male sexual dysfunction or vaginismus, we make sure that we are directly depositing the sperm inside the uterine cavity. So by all this process, we are increasing the chance of pregnancy by IUI. Nowadays, the use of IUI is increasing worldwide, especially in resource-limiting settings. Reasons are, one thing, there is advancement in sperm preparation techniques, especially after the discovery of in vitro fertilization, sperm preparation techniques are increasing. So this gives us a good quality sperm. So at the end of the day, the outcome of IVF as well as IUI is increasing significantly. The other thing, the complication rate of IUI compared to IVF is very low. In terms of infection, bleeding, ovarian hyperstimulation syndrome, there is less side effects regarding to IUI. It is also a simple procedure. Compared to IVF, it is very simple, it is closer to nature, so the acceptability by the community is also high compared to IVF. It is also an effective treatment for certain diagnoses. For example, in a patient with ovulatory dysfunction, like in PCOS patient, in a patient with unexplained infertility, we should not rush for IVF. The first line of treatment should be next to ovulation induction, it should be intrauterine insemination. The other thing, it is obvious, it is cost effective and affordable compared to IVF, and it is taken as an intermediate option between ovulation induction and in vitro fertilization. Regarding to accessibility, in most developing countries, it is very accessible because it doesn't need sophisticated facility. It only needs a well-trained gynecologist who can do transvaginal ultrasound and who has a good understanding of cycle monitoring. And on the laboratory side, we only need a well-trained lab technician who can do proper semen analysis and sperm preparation. Otherwise, it can be accessible for every country, especially for developing countries. The other issue that is raised is the success rate of IUI. Most of the time, the success rate of IUI may not be significant, but by improving at different level of IUI cycle, we can improve the outcome of the IUI. It starts with complete initial evaluation and workup with good patient selection. If you have a good ovulation induction, as a very important step, cycle monitoring. By monitoring the cycle, you can determine the right time of triggering, you can determine the right time of insemination. These all affect the outcome. The other important thing to increase the IUI success is improving semen preparation by giving training for laboratory technicians how to do semen analysis and good sperm preparation. And by improving the timing of insemination, the techniques of IUI procedure, you can improve the outcome of IUI success. For selected patient also, by giving luteal phase support, you can improve the IUI outcome. So I will see these things one by one. It is not only for IUI, before any fertility treatment, we have to follow the following things. As any patient, we have to take a thorough medical history and clinical examination. And as a baseline investigation, we have to do the following four important investigation. So the first investigation should be either it has to be transvaginal ultrasound or semen analysis. What I prefer is doing semen analysis should be the first diagnostic modality because one thing it is simple, the other thing it is less expensive, and it is also less invasive. And we all say that 50% of fertility is due to semen analysis. So semen analysis should be done as a first line investigation, but it has to be done by proper professional because what we are seeing currently, if you have wrong semen report, you will end up with wrong diagnosis and that will lead to delay in fertility treatment. So in a patient where you have prolonged infertility, especially more than 1 year, at least one times you have to do semen analysis by andrologist and urologist. These professionals are available at fertility center nowadays so that they will give you the right report of semen analysis so that you will not have delay in diagnosis. So semen analysis should be the first modality of investigation and it has to be done by andrologist. At least it has to be done as outpatient. You can send semen analysis as an outpatient for any fertility center so that we will have a right report of semen analysis. The other important baseline investigation is transvaginal ultrasound. Without this, I have doubt we are diagnosing correctly patient problem. For example, if you compare with transabdominal ultrasound, with transvaginal ultrasound, you can pick endometrial polyp or uterine syncytia or small submucous myoma that can easily be missed by transabdominal ultrasound. During our training of reproductive endocrinology and infertility, we spend most of our time by training ourselves doing the right type of transvaginal ultrasound. Otherwise, we will miss important findings. I wish every gynecologist trained for 1 to 3 months to have a proper transvaginal ultrasound examination. In addition of endometrial examination, it helps us to detect hydrosalpinx. Sometimes hydrosalpinx can be missed as a cyst that has a great impact on the outcome of fertility treatment. Because once you have hydrosalpinx, it is not only blocking the tube, the toxin inside the hydrosalpinx, it will affect the implantation, so it has to be removed before giving any treatment. And the other very important thing about transvaginal ultrasound, you can easily detect the ovarian reserve. Most physicians do day 2 FSH and estradiol to assess ovarian reserve. I don't think it is a proper way of assessing ovarian reserve because this hormone, especially the FSH hormone, it is indirectly secreted from pituitary. It doesn't show you the right ovarian reserve amount. So either you have to do antral follicle count or anti-Mullerian hormone, which is secreted from the ovary. So otherwise, FSH is a late sign to show a depletion of ovarian reserve because it starts to increase once the ovarian depletion significantly decrease. With transvaginal ultrasound, you can measure follicles between 2 to 10 millimeter. If the follicular number is between 10 to 50, that means the woman has normal ovarian reserve. If she has follicular count between 5 to 10, she has intermediate ovarian reserve. If she has less than 5, we say she has diminished ovarian reserve. So transvaginal ultrasound is the right hand in the diagnosis and treatment of intrauterine insemination. The other baseline investigation is tubal patency test. Everybody do hysterosalpingography, but everybody should know there is a false positive and a false negative result. So you should not 100% rely on the tests. Laparoscopy we may not do routinely, but in a patient, if you want to do additional procedure, for example, if you want to do laparoscopic cystectomy or ovarian ring or myomectomy, you can do also tubal patency test by laparoscopy. Or in a patient you have doubt on HSCG result, you can do laparoscopy. For example, recently I have encountered a patient, she is 25 years old, 1 year duration infertility, and there was no male factor infertility. HSG showed bilateral tubal blockage. Since she is young and the ovarian reserve is good and the male factor was good, we were having doubts. So we did laparoscopy, found that it was patent by chromoperturbation. So in selected patient, you can do laparoscopy as a tubal patency test. You cannot do laparoscopy for everybody because one thing, there is anesthesia exposure and there are surgical related complications. The other thing is ovarian reserve test. As I have said before, what we prefer as fertility specialists, we have to do antral follicular count and anti-Mullerian hormone as ovarian reserve tests. In low resource setting, what we recommend to do antral follicle count because it shows you early ovarian depletion compared to FSH and estradiol. These are FSH and estradiol are late sign. Once there is raised FSH and estradiol, it means already the ovarian reserve is depleted. The other hormonal tests that should be done for every fertile couple, TSH and prolactin. And during initial evaluation, also you have to discuss about the cost, the success rate, the potential complication of IUI, and you have to give also alternative management, including ovulation induction or IVF, and you have to ask if there are any inquiry. So the indications of the IUI, I said it is not absolute because we have also other alternative management. For every indication, we have ovulation induction or IVF that determined based on patient preference and after discussion with the patient. So the common indication for IUI, if you have unexplained infertility, if you have ovulatory dysfunction like PCOS, if you have mild to moderate male factor infertility. When you say mild to moderate, if the male has severe hypospadias or sexual dysfunction, if there is mild sperm parameter abnormality, if there is severe sperm parameter abnormality, IUI is not a good choice. If there is also female sexual dysfunction like severe vaginismus, IUI can be done under anesthesia for a patient with endometriosis, cervical factor infertility, donor sperm insemination with IUI, especially in a male patient who has severe and uncorrectable male factor infertility, who has inheritable genetic disease, or in a patient who is refused for any IVF, you can have an option of IUI. Contraindication of IUI, if there is cervical atresia, if there is active pelvic infection, we should not do IUI. If there is tubal blockage, obviously we don't do IUI. For male factor infertility, especially if the sperm parameter is severely affected, we don't do IUI. Azoospermia, there is no sperm that we infuse, so IUI is a contraindication. If there are genetic diseases that is transmittable to the newborn, we have to avoid IUI, not only IUI, IVF also. So the other very important thing in IUI is patient selection. We cannot use IUI for every patient. We have to select which patient will benefit from this procedure. So the most important thing is age, especially if the age of the woman is less than 30, the success rate of IUI is high. If it is less than 35, it is also good, but the effectiveness is significantly low when the age of the woman is more than 40. The other is duration of infertility. IUI is more effective if the duration of infertility is less than 2 to 3 years. When the duration of infertility is high, especially if greater than 5 years, the success rate is very low. So female factors ovarian reserve, the woman should have good ovarian reserve to do IUI. At least the FSH should be less than 7, AMH should be more than 1, AFSH more than 7. IUI is less effective if the woman has risk factor for dual factor infertility. If she has previous history of pelvic surgery like ectopic pregnancy or myomectomy or cesarean section, our patient selection may not be good. If one tube is blocked, our success for IUI will be affected significantly. Regarding to the male factor, you have to calculate total motile sperm count. You calculate by multiplying the volume of semen by sperm concentration by motility fraction. If this total motile sperm count is more than 10 million, you have a good candidate for IUI. Otherwise, if the total motile sperm count is less than 5 million, your success of IUI is less, so the result will be low and patient satisfaction will be less and treatment in general for fertility will be decreased. We get best outcome from IUI in a patient with unexplained infertility if there is mild male factor infertility and in a patient with PCOS. So when you see the general IUI cycle started on the second day of her period. She will come on the second day. We do transvaginal ultrasound. We will see whether there is cyst or not. If there is cyst, we don't start any treatment. If there is dominant follicle means if the follicular size is more than 10 millimeter, we don't start IUI cycle because it's going to affect our IUI outcome. We can start ovulation induction, either oral agent or injectable gonadotropin. We can appoint them after 8 days. During that time, we'll see transvaginal ultrasound. If the endometrial thickness is more than 60 millimeter, if the follicular size is more than 80 to 20 millimeter, we give trigger drug HCG that help for the maturation of oocyte and the release of oocyte. After giving HCG, after 36 to 48 hours, we will take the sperm, we process in the laboratory, and we inseminate inside the uterine cavity. After insemination, we start luteal phase support with progesterone. Luteal phase support, it depends on the patient condition. After 2 weeks, we will do pregnancy test by doing serum beta HCG. The first step in IUI cycle is ovulation induction. So we can make it natural cycle without any ovulation induction, but the chance of pregnancy will be low and the chance of cancellation of the cycle will be high. So we usually use either oral agent or gonadotropin as ovulation induction in intrauterine cycle. As oral agent, we can use clomiphene or letrozole alternatively. In most fertility centers, we use letrozole. One thing, it has less side effect compared to clomiphene. It has less effect on the endometrium, and there is also monofollicular growth compared to clomiphene citrate. That is why it is preferred, but you can use either clomiphene and letrozole as a first-line treatment, especially in a young patient with good ovarian reserve. In some patients, you can use gonadotropin, you can use HMG or FSH. Both are equally effective, but we don't use as a first-line treatment. We use in a patient with unexplained infertility, those who has a resistance with oral agent, in a patient with older woman, diminished ovarian reserve, you can use gonadotropin. In a patient with hypogonadism, you cannot use clomiphene or letrozole. The only option you have is low dose gonadotropin. Sometimes you can mix both oral agent and gonadotropin. This will reduce the cost of gonadotropin by shortening the duration of administration. Our goal during this ovulation induction is to have 2 to 3 follicles growing, not more than 3 follicles. So ovulation induction is very effective, especially in a patient with unexplained infertility and in a patient with PCOS. One thing one should know is when you use gonadotropin stimulation for ovulation induction, you have to consider expense. It is expensive drug, so you have to consider twice before you give gonadotropin during ovulation induction. Whatever drug you use, the maximum effectiveness you have for IUI is 20%. Not only that, when somebody use gonadotropin, it has side effect like risk of multiple pregnancy and ovarian hyperstimulation syndrome. So gonadotropin should be used by fertility specialists. Otherwise, we may end up with unnecessary morbidity and mortality for the mother as well as for the fetus. When we see ovulation induction versus IUI success, as I've said before, if you use a natural cycle, the success rate can be low, but by adding oral agent, you can increase the success rate. When you use gonadotropin, the success rate might increase, but the side effect like ovarian hyperstimulation, multiple pregnancy will be high, so you have to use cautiously gonadotropin. The other very important step is IUI monitoring. After giving ovulation induction, you have to see patient after a week. Especially if you use oral agent, you can appoint them after a week. If you are giving injection, gonadotropin injection, you have to see more frequently. Our treatment goal determined based on either estradiol determination or transvaginal ultrasound examination. So the estradiol level should be between 500 to 900 picogram per ml, and the follicular number should not be more than 3 mature follicles, especially in young patient and relatively old patient. You can have 4 to 6 mature follicles. When you say mature follicle, the follicle size should be between 60 to 20 millimeters. So the most important step in IUI cycle is monitoring, and you should know the target follicular number. Otherwise, you will end up with unnecessary complication. So as the number of follicles increase, the chance of pregnancy will increase, especially if you have 2 or 3 follicles, the chance of pregnancy will increase. But when you have more than 4 follicles, the chance of pregnancy will not increase. Rather, you are increasing the complication rate like ovarian hyperstimulation syndrome as well as multiple pregnancy. During cycle monitoring, sometimes we may force to cancel the cycle because if you continue the cycle, there is a risk of multiple pregnancies that will lead to premature delivery and fetal morbidity, as well as there will be risk of ovarian hyperstimulation that leads to third space, loss of fluid, and multiple organ failure. So in order to prevent that, sometimes we have to cancel the cycle, especially if the serum estradiol level is more than 900 picogram per ml. If you have 5 to 6 follicles with their size 10 to 40 millimeter, if you have follicular measurement more than 50 ml, and if you have more than 3 follicles, you have to cancel the cycle. By doing so, you can reduce the cost and you reduce the morbidity and the mortality. How can we cancel the cycle? We can give them a barrier contraceptive for 7 to 10 days not to have pregnancy. In some centers, they will aspirate the extra follicles, but this will add additional cost for anesthesia exposure. Sometimes you can convert it to IVF cycle, especially if you are working at fertility center. But converting into IVF cycle, it will add additional unexpected expense, and the outcome may not be that much improved. What are these triggering drugs? We have urinary HCG, recombinant HCG. Both are equally effective. You can use them alternatively. In some patients who has a risk of ovarian hyperstimulation, you can give gonadotropin releasing hormone agonist. It has short acting, so the risk of OHHS is less. The other thing is the timing of IUI. Once you give trigger drug, you can inseminate after 36 to 48 hours of trigger. The other is whether to do single or double IUI. American Society of Reproductive Medicine recommend a single insemination is enough, not double. In few selected patients, for example, in a male patient with oligospermia, you may do double IUI. That means you can do after 24 hours one insemination, the other insemination after 36 hours. But this is a very rare scenario. What we usually do, we can collect semen times 4 hours apart, and we can combine those semen sample and we can infuse. This is a very practical thing. After we trigger, the most important step is semen collection and sperm preparation. So during collection, we have to use sterile cup, and the male partner should have abstinence for 2 to 7 days. If there is abstinence less than 2 days, there is a risk of oligospermia. If the abstinence time is more than 7, the motility of sperm affects us. Preferably, the sperm is collected in the morning, and there are different ways of collecting the sperm. The other very important step is sperm preparation. The main purpose of this sperm preparation is to remove prostaglandin, cellular debris, WBCs, morphological abnormal sperms, dead, immature sperm. With also sperm preparation, we will enhance the capacitation, acrosomal reaction, and the motility of sperm so that you will increase the chance of fertilization. There are different methods of sperm preparation. I wish this can be presented by our andrologist and embryologist. I will not go through the details of the procedure, but I will tell you benefit and the drawback of each procedure. The first sperm processing is conventional washing. It is a simple washing. We remove seminal plasm and contaminants, but we don't remove dead sperm and bacteria as well as virus. So this kind of sperm washing is prepared for those who has low sperm viability and motility. The other way of sperm preparation is swim up technique. In this case, we select motile sperm. We may remove dead sperm. Still, there are bacteria, virus after this procedure. This kind of procedure, it is not recommended in a patient with low sperm count. The other is density gradient. In this method, we remove not only dead sperm, we also remove virus, bacteria. So it is preferred in a patient with HIV discordant. In a patient with HIV discordant, we use the combination of swim up and density gradient. Nowadays, there is also a new technique called microfluidic chips. There is small chips. You put a sperm on the chips, and that will select a motile sperm. This is technically it is very easy. Especially, it is being used for in a patient with a recurrent pregnancy loss, those who have recurrent pregnancy failure after IVF, but it is not currently available in Ethiopia. It might be somewhat expensive, but it is very easy to do sperm preparation with microfluidic chips. Which technique has high success rate? Both systemic review and meta-analysis has showed all the three methods are equally effective. So whatever methods that is convenient for you, you can practice it. As a beginner, standard sperm washing could be enough. In most fertility centers, swim up techniques are used. For those who have recurrent pregnancy loss, we may use the combination of swim up and density gradient. The other issue is the luteal phase support. After you do intrauterine insemination, you may start progesterone on the day of IUI. You should not start progesterone for every patient. It is only recommended if you use gonadotropin to stimulate the cycle. You have to use progesterone because in gonadotropin cycle, you have excessive estrogen progesterone that will inhibit LH secretion so that you will have short LH support. You have defective corpus luteum. In that case, administration of progesterone is very important. It makes the uterus very quiet. It increases the blood flow to the fetus. so that it will increase nutritional support. In addition to that, it is also progesterone is also immunomodulator. So especially in a patient with gonadotropin stimulated cycle, you have to consider routine administration of progesterone. In those with oral agent stimulated cycle, there is no need to give luteal phase support. As you all know, whatever techniques, whatever things you have used, sometimes the success rate of IUI is low. The reason could be improper patient selection. So as I will say repeatedly, proper patient selection is good. The success rate of IUI is good in young female patients, preferably less than 35 years, good ovarian reserve, patent tubes, short duration of infertility between 2 to 3 years. If there is no major male factor infertility, you'll have a good success. Otherwise, if you don't have a good selection, your success rate will be low. The other thing why we have low IUI success is suboptimal timing. If you do IUI too early or too late, the success rate is low. So the reason is once you do sperm washing, the survival of this sperm is only 2 to 3 hours because we don't have any cervical sperm reservoir in case of IUI. In natural cycle, after intercourse, some of the sperm may stay inside the cervix. But in case of IUI, once you bypass the cervix, there is no reservoir, so you have short time to have fertilization. Another thing, you have to do insemination after 36 to 48 hours of HCG. If you do late, the chance of fertilization is less because you have fertilization window of 12 to 16 hours. The other reason, unlike IVF, that you can see whether the sperm and the egg are join each other, whether they form embryo or whether they form morula or blastocyst. In IUI cycle, once you infuse inside the uterine cavity, you don't know whether it has joined the sperm, you don't know whether it has formed embryo, you don't know whether it has formed morula or blastocyst. Because there are many unknown things in the process, it is very difficult to know the success rate. In general, the success of IUI depending on patient factors. So it depends on the cause of infertility, it depends on the female age, ovulatory function, depends on the tubal patency, the semen parameter, whether we have used proper sperm preparation or IUI timing and the techniques. So we'll see how these factors affect our IUI success. When you see the success based on the sperm, if we are using partner sperm, the success rate may be low. If we are using donor sperm, the success rate obviously it is high. If you increase the number of cycles, the IUI success will be good. So in a young patient, if you do IUI 3 to 4 times, the success rate will be good. But in old patient more than 40, you should not try more than 2 cycles because the success rate after this will be low. The other factors which affect the success rate is the indication. If you have unexplained infertility, if you are PCOS patient, the success rate is good. In a male factor infertility, especially if it is only ejaculatory problem, the success rate is good. But if the cause of infertility is endometriosis, tubal factor, or a combination of factors, the success rate is low. So you need to advise on the other option of treatment like IVF. If you have only one tube is patent, based on the study done in France, it will reduce the success rate of IUI by 50%. So in a patient with unilateral tubal blockage, this literature recommends to have IVF. We cannot apply this for our setup, but during your counseling, you should tell for your patient that if there is only one tube is patent, the success rate is significantly affected, and you should not waste time on IUI. Not only on IUI, you should not waste time for ovulation dash and time intercourse. The other is maternal age. Maternal age significantly affects the IUI success. If you look at these researches, for example, in age less than 35, the success rate may reach up to 50%. In age more than 40, it's significantly decreased to 5%. Above the age of 43, the success rate is only 1%. So some centers recommend not to do IUI above the age of 40. So age is a very important factor for determining IUI success. Even you increase the number of IUI as the maternal age advances, the success rate will decrease. The other is duration of infertility. As I've said before, IUI is good for those who have short duration of infertility. As the duration of infertility increases, the success rate is very low. The other important determinant factor for IUI success is total motile count. If you have more than 10 million motile sperm, your success is good. If you have less than 1 million motile sperm, especially after processing the sperm, if you have this number, the success rate is very low. The morphology is also very important. If you have more than 4% normal morphology, the success rate is good. If the amount of sperm or the number of sperm is oligospermic, you can use 2 semens to increase the chance of pregnancy. So in general, you have to calculate the motility of sperm before you determine IUI. Otherwise, we are wasting the time of the patient. So this literature also shows the total motile sperm count increase, the success rate is high. If the total motile count sperm is less than 5 million, we have to think of other option of management. Poor outcome in general, IUI is found in a patient with age more than 35, if the infertility duration is more than 3 years, if the total motile sperm count is less than 5 million, if you have already 4 attempts of IUI, you have tubal factor infertility, like if one of the tube is blocked, if there is scanty spillage on HSCG, if there is previous pelvic surgery for myoma or delivery or ectopic pregnancy, if there is history of PID or TB, the outcome of IUI significantly affected. We can do IUI, but we should not spend time on the patients because she's going to lose her ovarian reserve from time to time. And by doing ineffective procedure, patient may not like the next treatment modality. So coming to what we need to do IUI, we don't need sophisticated instrument. Most of the things are available. Maybe we need a sterile cup or we need a catheter. There are different types of catheter, especially semi-rigid catheter are very important. We need sterile speculum, sterile gloves. We need a processed sperm. We need a syringe. We need a catheter, preferably semi-rigid catheter is preferable. We need a sterile saline solution. We don't use alcohol and iodine because they are toxic for the sperm. We don't use lubricant. If you have to use lubricant, you have to make sure that it is non-spermicidal. We need sterile drape. So most of these things are available in every gynecology center. So it is the issue of material is not the main reason not to do IUI. Recording is very important. Recording at the laboratory side as well as the clinician side is very important. Not to mix the sample is also very important. I think these are very routine and every laboratory technicians know these procedures. So you need to have a good recording, including the identification, the way you collect the sample should be registered, the semen parameter before washing and after washing should be registered. Regarding to clinician also, we have to put the diagnosis, the cycle monitoring, and what drug we have used for ovulation induction, and at what follicular site we have trigger. Everything should be registered. Coming to the IUI procedure, the patient should have full or partially full bladder that makes the anteverted uterus to make it straight. and we have to verify the patient name with the processed sperm. We have to put the patient in dorsal position with hip and knee flexed, hip slightly abducted. We can insert bivalve speculum. We have to be gentle. We have to be gentle, and we have to clean the vagina, cervix by normal saline only. We should not use alcohol. We have to remove cervical mucus, and before any procedure, especially during cycle monitoring, you have to know the direction and length of uterine cavity. After that, the catheter should be inserted very gently into the cervical canal. You have to insert 6 to 6.5 centimeter. You should not touch the fundus of the uterus during the procedure. As much as possible, you have to use the catheter, which is non-toxic, disposable, and soft or semi-rigid catheter should be used. And the prepared sperm the amount should be between 0.3 to 0.5 ml sperm. You have to infuse slowly inside the uterine cavity over 10 to 30 seconds, and you have to fix for some time before you withdraw the catheter. And as much as possible, you have to avoid the use of ALICE or tenaculum because it will stimulate the uterine contraction. In general, the IUI procedure should be gentle, and you have to be sterile, and you have to avoid unnecessary invasive procedure during that time because uterine contraction may cause expulsion of the sperm. So after the procedure, patient can remain in supine position for 10 to 15 minutes. Even though there is no strong evidence for this, we can discharge the patient immediately after the procedure. We can schedule for pregnancy test after 14 days, preferably by serum-based HCG. And we have to tell them some of the danger signs. There could be mild crampy pain, discomfort, or wetness that you can reassure them. For few patients, especially those who used gonadotropin stimulation, we can use luteal phase support with progesterone. Sometimes we may face difficulty IUI. Sometimes you may have difficulty in negotiating the catheter through the cervical canal. In that case, there are some tricks that you can do. For example, if it is anteverted uterus, you can fill the bladder and you can make it straight. You can use ultrasound guidance. As a beginner, if the ultrasound is available, you should do it under ultrasound guidance. It will increase your confidence. And sometimes by just manipulating the speculum, you can make the procedure very easy. So a speculum manipulation and making the cervix central, it will make the IUI procedure very easy. Sometimes you may use traction of ALICE to straighten the uterocervical angle. In very difficult cases, you can do intracervical insemination. I know it may decrease the success rate, but sometimes it could be the only option available you have. In difficult situation, if you are not succeeded, next time you can consider hysteroscopy and cervical dilatation before you start the next IUI cycle. The other is whether to do sexual intercourse after IUI. It is recommended to do sexual intercourse after IUI. It will benefit, it doesn't harm anything. So you have to encourage to have sexual intercourse on the day of IUI as well as on the next day. There are also new instruments available for intrauterine insemination. So maybe in the near future, we may have this slow releasing insemination device that can assist you in inseminating the prepared sperm. How many number of IUI cycle is enough? That depends on the patient. The female age, duration of infertility, coexisting of infertility factor, and the sperm quality. So in general, it is recommended to do IUI cycle for 3 to 6 cycle. This 3 to 6 cycle is for young female, short duration infertility, patent tube, if there is no severe male factor, infertility, if the duration of infertility is short, you can try 3 to 6 cycles. But I can tell you frankly, patient will not give you this kind of chance. Uh, they may try for 1 to 2 cycles, not more than 3 cycles most of the time in clinical practice. So you should give them other option. So the decision of IUI versus to IVF, it is not straightforward always. You give them every evidence, the choice is by the patient. So when you counsel them, you should counsel them based on the expense. Obviously, IUI has less expense compared to IVF. If they want to have pregnancy quicker, IVF is preferred way of treatment. If they want to reduce risk of multiple pregnancy, IVF is preferred because in IVF, especially in modern ART treatment, single embryo transfer is preferred. So with that, you can control the number of pregnancy. But in IUI, you cannot control this. So to reduce the risk of miscarriage, IVF is much preferred, because, especially in a place where you do pre-implantation genetic testing. IVF is more preferred. Obviously, IUI has less burden compared to IVF. If a woman needs future family planning, IVF is preferred because with one IVF cycle, you may have 4 or 6 embryo that can be used for future fertility. Regarding to the risk, IUI has less risk. So when you decide for IUI or IVF, it is not only the success that determines the thing. It is the whole package discussion that help in decision making, and the patient should take the leading in this decision making. So in general, in a patient who has unexplained infertility, a staircase approach is important. First, you have to advise on lifestyle modification. You can try oral agent with timed intercourse. That this doesn't work, you can give oral agent with IUI. Then you can add gonadotropin with IUI, and at final stage, you give the option of IV. So when you see the complication of IUI, one of the major complications is failure. So the maximum success that you can have is 25%. The remaining 75 may not be successful. But if you have a good pre-procedure counseling, this is well accepted by the patient. There are also rare complications like wrong semen sample used. These are a very rare condition nowadays, especially in fertility centers, and transmission of infection, uterine contraction, anaphylaxis. These are rare nowadays because we are using a processed sperm. The other complication is risk of multiple pregnancy. We risk of twin, high order pregnancies, high, especially if you use gonadotropin stimulation for IUI. And the other catastrophic complication is ovarian hyperstimulation, but you can prevent this complication by vigilant use of gonadotropin, by cycle monitoring, and ready to cancel the cycle. Or by converting to IVF, you can reduce the risk of ovarian hyperstimulation. In general, IUI is a very simple procedure. It is non-invasive. It is a cost-effective, office-based procedure. It can be practiced at any gynecological center as long as we have a well-trained gynecologist who can do transvaginal ultrasound and who can understand the importance of cycle monitoring. And as long as we have a trained lab technician who can do proper semen analysis and semen preparation, it is very easy to do at any center. And you have to make sure that you have good patient selection. You have to select a young patient who has patent tube, in a patient with no severe endometriosis or male factor infertility, short duration of infertility. IUI should be the first line of treatment. Otherwise, if you have a bad patient selection, patient will fatigue and give up on the treatment of fertility treatment in general. So best practices, careful couple selection, well-timed single IUI, avoid use of gonadotropin. During the procedure of IUI, you have to be gentle, you have to avoid touching the fundus, or you have to avoid endometrial injury. And advantage over IVF IUI, it is simpler and cheaper. Before you start any IUI, you have to counsel about the efficiency and the risk. IVF gives you high pregnancy rate, it reduces the risk of multiple pregnancies. It allows embryo cryopreservation. In the future, we have to phase out the use of gonadotropin. During IUI, we have to prefer IVF in case of severe male factor infertility, endometriosis, or if you have any suspicion for tubal factor damage, you should not waste your time in IUI. IVF clinics should better manage complications like HHS and multiple pregnancy. Thank you. If you have any question, you're welcome.